My name is Minesh Mehta. I'm a radiation oncologist at Miami Cancer Institute, which is part of Baptist Health of South Florida. I had the pleasure today of presenting the data from the METIS EF25 trial. This was a randomized multicenter international phase 3 trial. The purpose of the trial was to investigate whether in patients with non-small cell lung cancer with brain metastases, whether we could make a difference in intracranial failure rates by adding this new therapy called Tumor Treating Fields, which is an electrical field device. So patients with brain metastases on this trial were randomized 1-to-1 to receive stereotactic radiosurgery, which is a very common therapy for these patients. And after stereotactic radiosurgery, they would receive the standard of care, or they would receive the standard of care plus tumor treating field therapy. The goal was to see if we could reduce failure rates in the brain. Overall, across the board, the top-line results show that there was a 10.6-month improvement in median time to intracranial progression or intracranial failure. This is a substantial improvement in the intracranial control rates on patients. We also looked at the quality of life of patients, and the quality of life was measured using a validated tool, and we mapped that out as a quality of life improvement called deterioration-free survival. And the deterioration-free survival also favored patients on the Tumor Treating Fields arm. One more important finding from the study was the safety profile. The device was well tolerated. Some people get skin reactions, but these are mild, and high-grade toxicities are very, very uncommon. So as an overarching summary, what we found was a positive result, an improvement in time to intracranial progression by 10.6 months, a good safety profile, and improvement in quality of life. So this study is very interesting in terms of positioning ourselves in the realm of what is next. A little more than a year ago, a trial called the LUNAR trial was presented, where the same device, tumor treating field device, was applied to the thorax in patients with metastatic lung cancer. And that study showed an improvement in overall survival in patients. So if we now put these two studies together, applying the device to the thorax improves overall survival in patients with metastatic disease. Applying the device to the brain in patients that have brain metastases delays time to progression in the brain. So what if we have now patients with brain metastases who also have extracranial disease, and we apply the device both to the brain and the chest? Could we not improve just the intracranial progression-free survival, but perhaps also overall survival? That's a very important question. Another important question is that in this trial, we excluded patients who could receive what we call targetable therapies for actionable mutations. And the reason for that is these therapies have a high initial rate of response, but they all eventually suffer from the same issue of subsequent failure in the brain. Could we perhaps prolong the benefit from these targetable agents by adding tumor treating fields? Perhaps another study could answer that question. So these are at least two different opportunities that are worth evaluating. Well, I think Tumor Treating Fields is an interesting new therapy. It's a therapy that is unconventional in the sense that it's not a systemic therapy, it's not surgery, it's not radiation. These are the typical therapies that one sees in the oncology armamentarium. Tumor Treating Fields therapy has slowly but surely been demonstrating positive results in a multitude of clinical settings. First in recurrent glioblastoma, then in newly diagnosed glioblastoma, then in pleural mesothelioma, then in metastatic disease from lung cancer from the thorax, and now most recently from the METIS trial. So I think the abundance of evidence that's developing is supporting this therapy as a very real and reasonable approach in oncology.